Hello everyone, welcome to the first masterclass on this channel. I am Dr. Naveedul Zafar, a clinical physiotherapist working in a hospital, mostly with musculoskeletal patients. And today we are doing something different, something deeper. Here's how these masterclasses will work. I will show you a clinical MCQ, a real case, the kind you see in your OPD. Then I will read it out, and then I will ask you to pause the video and think of the right answer. Really think, don't just guess. When you are ready, press play and I will walk you through every single option, why three are wrong and why one is right. Not just memorization, real clinical reasoning. Along the way, I will explain the basic concepts, the anatomy, the pathology, the clinical logic, just like a senior colleague sitting with you after a long OPD, explaining things simply, no complicated English, no unnecessary jargon, just the practical physio knowledge that sticks. Today we have two shoulder cases. Both are tricky, both are common, both are the kind of cases that confuses fresh graduates. So grab your notebook, pause when I tell you to, write down your answers. Let's begin. Before we begin, let's quickly revise one basic concept that confuses many of us. The shoulder joint is like a golf ball sitting on a tee. The socket is shallow. To make it deeper and more stable, the body has a rim of cartilage around it called the labrum. Think of it like a rubber seal around the edge of a jar. It deepens the socket and creates a suction effect. Without it, the ball slides around too much. Now, just above the shoulder joint is another important structure, the AC joint, where your collarbone meets the shoulder blade. These two produce very different types of pain. Confusing them is common. Today's MCQs will test exactly this. We will cover two cases. First, a young athlete with a shoulder that feels unstable. Second, a middle-aged man with top of his shoulder pain that just won't go away. Both are real clinical scenarios. Both are tricky. Let's get started. Here's case number one. A 22-year-old cricketer presents with shoulder pain after a diving tackle 2 weeks ago. He says his shoulder sometimes feels like it's slipping out when he throws, followed by a dead heavy feeling. On examination, the apprehension test is positive. The relocation test relieves his symptoms. What is the most likely diagnosis? Option A, rotator cuff tear. Option B, anterior shoulder instability with a possible labral tear. Option C, subacromial impingement. Option D, AC joint sprain. Pause, think. The keyword here is slipping out. Write down your answer. Press play when you are ready. The correct answer is B, anterior shoulder instability with a possible labral tear. Let me explain why and why the others are traps. Option A, rotator cuff tear. This is the most common wrong answer. Yes, the patient is an athlete. Yes, there's shoulder pain. But a cuff tear doesn't typically make the shoulder feel like it's slipping out. Cuff tears cause weakness and pain, not instability. And a 22-year-old with no degenerative history, a traumatic cuff tear is possible, but the apprehension test being positive point us somewhere else. Option C, subacromial impingement. Impingement pain comes on gradually, typically with overhead activities, and you get that classic painful arc. But this patient's pain started after a trauma, a diving tackle, and the sensation of the shoulder slipping out. That's not impingement, that's instability. Impingement does not make the joint feel loose. Option D, AC joint sprain. An AC joint injury gives you very localized pain right on top of the shoulder. The AC joint, you might see a step deformity if it's severe, but the apprehension test is not positive in AC joint injuries. That test is specific for anterior instability of the glenohumeral joint. Option B, anterior shoulder instability with a possible labral tear. Now let's understand the basic concept. When the shoulder dislocates or subluxes anteriorly, which is the most common direction, the labrum at the front of the socket can tear. This is called a Bankart lesion. Once that labrum is torn, the socket loses its depth, the ball can slide forward. That's why the patient feels it slipping out. The apprehension test, you take the arm into abduction and external rotation and then gently push the humeral head forward. A patient with anterior instability will feel like the shoulder is about to dislocate. They will resist you. They look scared. That's why it's called the apprehension test. And the relocation test, you push the humeral head backwards and suddenly they feel safe. The combination is almost diagnostic for anterior instability. So, here is your takeaway. Number one, slipping out sensation equals instability, not impingement. Number two, a positive apprehension test points towards the anterior instability, often with a labral tear. Number three, in young athletes with traumatic onset, always think instability before cuff pathology. And number four, these patients need stabilization rehab, not just general shoulder exercises. Case number two, a 45-year-old man presents with 6 weeks of pain at the top of his right shoulder. He works as a carpenter and lifts heavy tools overhead daily. He points directly to the AC joint. The pain is sharp and worsens when he reaches across his body to grab the seat belt. There is no painful arc. Hawkins, Kennedy, and Neer's tests are negative. What is the most likely source? Option A, subacromial impingement. Option B, AC joint pathology. Option C, biceps tendinopathy and glenohumeral arthritis. Pause. Notice the location of pain. Notice which tests are negative. That's your clue. Write your answer. The correct answer is B, AC joint pathology. Let's break it down. Option A, subacromial impingement. This is the default diagnosis many new grads use for any shoulder pain. But look at the clues. He points directly to the AC joint on top of the shoulder, not the lateral deltoid area. There is no painful arc. Hawkins, Kennedy, and Neer's test. Your classic impingement tests are both negative. If it were subacromial impingement, these tests would be positive. They are not. So it's not impingement. Option C, biceps tendinopathy. Biceps tendon pain is felt at the front of the shoulder in the bicipital groove. It hurts with Speed's test or Yergason's test. Our patient's pain is on top, not in front, and his pain comes with cross body movement. That's not a biceps test. Different location, different vocative maneuver. Option D, glenohumeral arthritis. Arthritis of the main shoulder joint causes deep pain, often felt in the back of the joint or the front. It comes with crepitus and a loss of both active and passive range. This patient's pain is superficial, right at the AC joint, and there is no mention of crepitus or global stiffness. OA doesn't fit. Option B, AC joint pathology. Now let's understand why. The AC joint is a small joint between the clavicle and the acromion. It takes a lot of load, especially in people who do overhead work. Over time, it can develop osteoarthritis or it can become inflamed. AC joint capsulitis. The hallmark is pinpoint tenderness right over the joint and pain with horizontal adduction reaching across the body. The test you use is called the scarf test or cross body adduction test. You take the patient's arm across their chest, and if it reproduces that pinpoint pain at the AC joint, the test is positive. It's simple, but you have to know it and look at the clinical picture. A carpenter, overhead work, gradual onset, localized pain, negative impingement tests. That's AC joint pathology. So, your takeaways: number one, not all shoulder pain is impingement. Number two, top of shoulder pain, especially with cross body movement, think AC joint. Number three, the scarf test is your best friend for AC joint assessment. Number four, always let the examination guide your diagnosis, not your assumptions. If impingement tests are negative, look elsewhere. Alright, two very different shoulder cases. One is about instability deep in the joint, and the other is about small but painful joint on top. Both are real, both are common, and both will add up to your clinical knowledge and will make you a sharper clinician when you understand them. That's your first masterclass done. Two cases, two concepts, multiple clinical pearls that will change how you assess a shoulder. I want you to comment below how many did you get right? Be honest. And if you learned something new, tell me what it was. Thank you for being here. I'm Dr. Naveedul Zafar. Keep learning, keep thinking, and I'll see you in the next masterclass.